It's my great privilege to give the Charles Boucher Memorial Lecture. I have met Charles on several occasions. He's a wonderful clinical scientist and a very, very fine gentleman. And it's a tribute, it's a great to giving this tribute to him. This was a card I received after the Nobel Prize, and it was very meaningful to me because I think it said a lot about clinical research in general. It said, there is no elevator to success. You have to take the stairs. This is a message that's worth remembering. And what I'm going to do today is take you through the stairs that led to the discovery of hepatitis C. We started in the late 1960s with this prospective study of open heart surgery patients, and we're looking for the incidence of transfusion-associated hepatitis. These patients were all on an open heart-lung machine. They received an average of 17 units of blood per patient, so they're heavily transfused. And the main point is we were following them prospectively, so we had samples every 1 to 2 weeks post-transfusion for 3 months, and then every month for an additional 3 months. We saved all these samples in frozen storage, and we saved the donor samples as well. But the only things we could measure in the patient at that time were ALT and hepatitis B surface antigen. We had no tests for any other viral agents. The first thing we found was this inordinately high rate of hepatitis. Over 30% of these patients developed post-transfusion hepatitis prior to 1970. And we found that the reason for this was that it highly depended on the source of blood, that if they received at least 1 unit of paid donor blood, there was a 51% chance of developing hepatitis, whereas they received only volunteer donor blood, there was only a 7% risk of hepatitis. Thus, in 1970, we were able to move to the next step, and that was to adopt an all-volunteer donor system and introduce the first generation and then second generation tests for hepatitis B surface antigen. As you can see, in 1970, this resulted in a precipitous fall in hepatitis incidence from 33% down to just under 10%, even though the number of units of blood transfused remained almost the same. Nothing we've ever done, in fact, since that time has had such an impact because the rates of hepatitis were never so high again. In 1973, Abbott Laboratories developed a more sensitive third generation assay for hepatitis B. We went back to these non-B samples, and found that only about 25% of cases were due to hepatitis B, and thus there was some other non-B entity, which was the predominant cause of post-transfusion hepatitis. In 1975, Feinstein, Kapickian, and Purcell at NIH, who were our collaborators, discovered the hepatitis A virus using immune electron microscopy. And we immediately sent our non-B samples to Steve Feinstein, and he tested them, and not a single case of non-B hepatitis was due to hepatitis A. And it was then in a brilliant step of deductive reasoning that we said if these cases were not A and were not B, we'd call this NonA, NonB hepatitis. Now we kept this awkward name rather than hepatitis C because we hadn't yet proven that we had a viral transmissible agent. And if so, we didn't know how many agents there might be. This led to the next step, or chimpanzee studies, chimp transmission studies. Chimps did not get sick from hepatitis, but they did get ALT elevations, liver enzyme elevations. Importantly, we were able to transmit to the chimp from patients who had both acute and chronic NonA, NonB hepatitis, and also from asymptomatic blood donors who had been implicated in hepatitis transmission. So now we had a chimp model. And the next step was this famous patient, patient H, a single patient from whom we learned more than any other I've ever studied. Mr. H was a trailblazer. He liked to climb mountains and mark trails. And on one such occasion, while on a mountain, he had a cardiac arrest. And he would have died, except that his wife was with him, who knew CPR. She was able to resuscitate him, and eventually he got back and was admitted to NIH. This slide shows his clinical course. In blue are the ALT elevations indicating hepatitis. Focus on that for now. You can see that about 5 weeks post-transfusion, the ALT level began to rise and then rose very precipitously, reaching a peak of 2,112, where 40 was the upper limit of normal. Fortuitously, we obtained a plasmapheresis unit at point A on the ascending limb of the ALT curve, inoculated that into a chimpanzee as shown in the upper right panel. This caused hepatitis in the chimp. And Bob Purcell then did infectivity titers in other chimps and found that Mr. H had a infectivity titer of 1 × 10⁶.5, which proved almost identical to later HCV RNA titers. While the patient was quite sick and jaundiced, his ALT level then dropped very rapidly and he recovered, but became a chronic persistent carrier for the rest of his life. We followed him for 30 years. If you look at the yellow line, you'll see this is the HCV RNA levels that we were able to do much later on. We went back to the stored samples, and you can see that right after transfusion, there was a small blip in HCV RNA. This was the virus coming from the blood donor. It then was contained, but then a subsequent virus began to rise very rapidly and cause the subsequent hepatitis. I won't go through the other measures on this slide. Having now this patient and a titered inoculum and the chimpanzee model, we could then do manipulations. And Steve Feinstone did this chloroform extraction, showing that if you extracted the H inoculum with chloroform, it did not cause hepatitis. It prevented hepatitis transmission, whereas a sham extraction allowed hepatitis to occur. Thus, we knew there was a central lipid in the viral envelope, and this was important in further classifying the virus. We also did filtration studies using the chimp again, and showed that the virus was quite small. So even before the virus was ever seen or cloned or cultured, we knew that it was going to be a small agent that had a lipid envelope. And this narrowed it down to being one of the small RNA viruses, the so-called alpha and flaviviruses. Could have been a hepatitis B-like virus, but we had a lot of evidence that it was not related to B. So it was either going to be a new class of viral agents or a small RNA virus, as it proved to be a flavivirus. Now, we kept trying to develop a specific assay, but could not come up with one. But meanwhile, we studied the patients, did liver biopsies in 39 patients. While most had mild to moderate chronic hepatitis, 10% already had cirrhosis and 13% had severe chronic active hepatitis that was likely to progress to cirrhosis. We did follow-up biopsies in 20 patients. While most were stable or even looked improved, 25% progressed to cirrhosis under observation. So we wound up with 8 out of 39, or 20%, who developed cirrhosis, a figure that is pretty well held up over the decades. It's somewhere between 20 and 30% of patients with hepatitis C who develop cirrhosis. And importantly, of those patients, 3 of them died of liver failure, and 3 others had severe liver disease when they died of other intercurrent events. Now, we tried everything in those from 1975 through 1985, but we were not able to come up with a specific hepatitis NonA NonB assay. And it was then that I wrote this poem of frustration that I called "I Can't See the Forest for the HBAGs." It went, "I think that I shall never see this virus called NonA NonB, a virus I cannot deliver, and yet I know it's in the liver. A virus that we often blame, but which exists alone by name. No antigen or DNA, a little test to mark its way. A virus which in our confusion has forced us into mass collusion to make exist just by exclusion. But is it real or an illusion? Oh, great liver in the sky, show us where and tell us why. Send us thoughts that will inspire us. Let us see this elusive virus. If we don't publish soon, they're going to fire us." Well, I presented this at a national meeting, and I think it had a great influence on the Chiron Corporation, because shortly thereafter, Michael Houghton and his group at Chiron, excuse me, cloned the hepatitis NonA NonB agent and called it hepatitis C. They did this by pelleting high titer chimp infectious material, extracting the RNA, cutting that with restriction enzyme, reverse transcribing it, and then cutting it with restriction enzymes, and importantly, inserting it into a phage GT11 expression vector. This was a phage that would not only carry forward the genome, but would also express any protein coded for by that genome. They used this phage to infect E. coli, then lyse the E. coli onto filter paper, and then screen the filter paper with convalescent serum from NonA NonB patients. This was also a unique step because we'd never seen an antibody, but Michael Houghton assumed there must be one present. Interestingly, the company screened 6 million clones before they found a single clone that was reactive with this antibody. But then they were able to subclone it to express some proteins, and with these proteins able to develop an antibody assay to hepatitis C virus. This is Michael Houghton. At the time, he received the Lasker Award, which I shared with him, and also the Nobel Prize, which I was lucky to share with he and Charlie Rice. Now, when Chiron thought they had cloned the agent, they asked for the NonA NonB panel that I had developed. This was a small panel, but it was tricky in that everything was in duplicate, and all the duplicates were in random positions. 19 other laboratories who claimed to have a NonA NonB assay were unable to break the code of this panel. But Chiron broke it perfectly. They detected 3 out of 3 patients with chronic NonA NonB in 6 different random samples. They detected 2 implicated blood donors in 4 different random positions. They did not detect the patient with acute NonA NonB because they were looking for antibody and not virus. But later, these 2 patients also seroconverted for antibody to hepatitis C. Importantly, they did not detect antibody in 7 negative controls, highly pedigreed negative controls in 14 different positions. So they broke the code perfectly. Then I looked at 15 of our NonA NonB cases, and in every case, the patient was negative for this antibody pre-transfusion and became positive post-transfusion. We then looked at the 25 non-A NonB cases, looked at the donors to those cases, and found a positive donor in 80% by a first generation assay, 88% by a second generation assay. So we could predict that we might prevent near 90% of post-transfusion hepatitis if we introduced this test, which we did in 1990. On this slide, you see the tracing of the incidence of post-transfusion hepatitis from the very high rates prior to 1970 down through different interventions. Now here in 1990, introduction of the first generation test for hepatitis C, which dropped the rates from 4.1% to 1.1%, a second generation assay in 1992. And by 1997, we had reached 0 incidents in this prospective study. It doesn't mean that hepatitis C can't be transmitted, but it can now be mathematically calculated that the risk is about 1 in 2 million transfusions compared to the original risk of 1 in every 3 transfusions. So this was quite dramatic. We could estimate using these incidence figures and extrapolating to the whole US population that between 1970 and 1990, there were probably near 5 million HCV infections transmitted by blood transfusion. And conversely, from 1990 to 2010, that we probably prevented 2.4 million subsequent infections. Now, looking at the clinical course of our patients, it was clear that most patients had a very slow progression and stable, relatively stable course. They remained HCV RNA positive, antibody positive, but did not progress to bad sequelae over many, many years of follow-up, some for their whole lifetime. On the other hand, 20 to 30% developed cirrhosis in 20 to 40 years, and a small proportion had very rapid progression, getting cirrhosis in 5 to 10 years. So with Patricia Farsi, we were interested in looking at the differences between the slow and the rapid progressors. And you see the slow progressors shown here in the yellow had an initial rise in HCV RNA, but then it came down and almost disappeared. But then a mutant, a new variant of hepatitis C took over. The HCV RNA levels went up again, and then the patient went into a persistent carrier state. In contrast, the rapid progressors never had this big initial drop in viral load. They were always persistently high. We found that these rapid progressors also had high levels of MCP1, monocyte chemotactic protein, which is a pro-fibrogenic chemokine that attracts stellate cells in the liver. These stellate cells are the main producers of collagen that lay down fibrosis. So it attracted the stellate cells, and the stellate cells produce more MCP1, and you had this cycle of progressive stellate cell activation, collagen deposition, and fibrosis progression. Slow progressors, on the other hand, had good cytokines, interferon gamma, MIP1 beta, which were anti-inflammatory. We're now at a stage in hepatitis C where almost all these patients, whether rapid or slow progressors, can be cured with direct-acting antivirals. You can cure in some studies 100%, certainly over 95%. And that raises the question of whether hepatitis C could actually be eradicated. Now, we have these great drugs, as I said, 95 to 100% cure rates. We don't currently have a vaccine for hepatitis C, so that's not going to help right now. But to get to global eradication, we do need this little miracle to occur. But the miracle has some measurable components. To get rid of hepatitis C, particularly in Africa and other global places, one needs to adopt universal precautions to prevent medical practices from using shared needles or using shared syringes or vials. Everything has to be disposable. That would have a major impact on hepatitis C transmission. We need to detect almost all HCV carriers through massive global screening. This is a very difficult task, but it could be done, as already shown in Egypt, where they screened almost the entire population. The global screening has to be linked with global delivery of direct-acting antivirals, penetrating at least 90% of the population. What I envision is a rapid test for HCV. One could be tested in the field or a doctor's office, and immediately, if testing positive, given the first month or 2 months supply of the drug, which will be sufficient to cure the patient. So what we need now is the political, the corporate, the philanthropic, and moral will to make this happen. It's a difficult task. I think Africa is going to be the model for doing this. As I said, Egypt has already done it, and we need to go country by country to help eradicate hepatitis C. So I just want to end now with another poem, which I call The Ode to HCV. Your days are numbered, my fine feathered friend, with drugs now attacking your enzymes and your 3' end. Drug after drug is on your case, snuggling up to your protease. Try to replicate without your polymerase. Your non-structural proteins are now big targets. They're selling your pieces on the open markets. More than half your victims are already cures, and 95% responses the future ensures. HCV, you're on your way out. A few more years and you have lost your last, you've had your last shot. At meetings you will no longer talk about. You'll be a virulent, have lost all your clout. Of your ultimate demise, there is now little doubt. In many ways, I'll miss you. You've been a good foe. We've waged a long battle, gone to and fro, and along the way, you've improved my cash flow. Shouting your swan song is now apropos. So thank you very much. And again, a tribute to Charles Boucher, a wonderful scientist.